Greetings, everybody. Welcome to the Robert Wood Johnson Foundation Systems Through Action Research Program and our regularly recurring Research in Progress webinar series. Thanks so much for joining us. For those of you who might be new to this session, this is a session we do typically a couple times a month. And again, it's sponsored by the Robert Wood Johnson Foundation Systems for Action Research Program. S4A as a research program is designed to study innovative ways of better connecting medical care, public health, and social service delivery systems with the goal of improving population health and, very importantly, tackling difficult issues around health inequities for populations that experience them. We take this webinar as an opportunity to give you an early look at findings from research studies that are ongoing within this program. For today's webinar, we're fortunate to have colleagues with us from Humana Health Plan, and we'll be presenting findings from a study of population health improvement strategy that Humana has been sponsoring called Bold Goal. So with that, let me share my screen. And we can get started. Just make sure, yes, right. Fantastic. So let me, I'll first give you an introduction to our presenters and panelists today. This is actually a collaborative research study that has been conducted both with members from our intramural research team at the University of Kentucky, along with a number of colleagues at Humana Health Plan. I'm sorry, our intramural research team at University of Colorado, along with colleagues from Humana Health Plan, and also colleagues from the University of Kentucky School of Public Health. And so we will go through some introductions and then step you into our research and what we're learning through this project. Well, this is a slide about me. I guess I should introduce myself, Glen Mays. I am here at the University of Colorado. I direct the National Program Office for the Systems for Action research program on behalf of the Robert Wood Johnson Foundation. I'm also a professor here in the Colorado School of Public Health and chair our Department of Health Systems Management and Policy. And we're also fortunate to have with us today several colleagues from Humana Health Plan who have been collaborators on this study as well, including Dr. Jessica Dobbins, who has been at Humana since 2005. Her work focuses on a variety of community health initiatives, as well as work looking at alternative payment models and health outcomes research in the context of Humana and its members. She's currently Associate Director within Humana's Office of Health Affairs and Advocacy on the Strategic Relationships team, which, as you'll learn, is very relevant to the topic today and to the Bold Goal initiative that we'll be describing. We also have with us today Stephanie Franklin, another really key collaborator with us in this initiative, also with Humana Health Plan. She is the population health strategy lead supporting Humana's Bold Goal, which we'll be describing here shortly, with a focus on improving the health of the communities that are served by Humana through this initiative. She leads strategy and execution of a number of components of this initiative, including the social needs survey that's conducted as part of Bold Goal, and as well as is involved in the predictive modeling and social risk analysis work that's a key part of this initiative as well. And I do also want to acknowledge, as I mentioned, we've got a much larger team of collaborators who've been working with us on this program as well. Dr. Andrew Reyna, Dr. Angela Hagan, and Courtney Brown, Dr. Todd Pruitt, all other members of Humana Health Plan. And then I mentioned our colleagues at University of Kentucky. This collaboration started with a collaboration between University of Kentucky and Humana. And our colleagues, Dr. Teresa Waters and Dr. Larry Pribble, are also have been key collaborators with us in this study. So I also do want to acknowledge that this work has been supported with funding provided both by Humana Health Plan as well as the Robert Wood Johnson Foundation through the Systems for Action Research Program. And as I mentioned, the authors from Humana are all affiliated, obviously employed by Humana. And I'm obviously connected and funded by the Robert Wood Johnson Foundation. Okay, so with all of those introductions complete, I'm going to turn it over to our colleague, Dr. Jess Dobbins, to kick off our presentation today.
Wonderful. Yeah, thanks, Glenn. Great introduction. Today, we're really excited to share our work, and we'll be sharing with you our study of the community level effects of our Humana Bold Goal work, which you'll be learning more about here in a second. So we'll start by introducing you to Humana's Bold Goal and multi-sector partnerships. We'll offer an overview of our analytics, as well as a broad overview of the National Longitudinal Survey of Public Health Systems data. And then we'll conclude by discussing some of the implications of our findings, as well as next steps. So really looking forward to your questions and rich discussion at the end of our presentation. So I'll turn it over to Stephanie to really kick us off and familiarize you with Humana's Bold Goal. Thanks, Stephanie.
Thanks, Jess. So Humana declared our Bold Goal in 2015 to improve the health of the members in the communities we serve by 20% by 2020. And this 20% was meant to be a really measurable goal, and we're using the Healthy Days measure, which was developed by CDC to measure health-related quality of life. And we're using that to track our progress from the baseline year 2015 through, well, today. And we chose Healthy Days because it is self-reported. It is really holistic. It factors in both physical and mental health. And it's pretty easy to administer and track progress for the population. And you can go ahead, Glen, the next slide. We kicked off our initiative in 7 communities. They're here in Plum in 2015. And we really wanted we selected communities to go deep into with our population health activities. We selected them based on factors like where we actually have a concentration of Humana members, where we have a Humana office and good engaged associates on the ground who are really invested in the community. We started off by hiring a population health lead for each community, someone who's employed by Humana on the ground who can create those relationships in the community with different stakeholders and really activate Humana, the Humana associates who are there around population health. We have since expanded the Bold Goal. You can see we still are primarily located in the South and Midwest. Go on, Glen. So no surprise, this stat is not new to anyone on this call, I know, but as we really looked at how do we make it easier for everyone to achieve their best health, it really drew us to these upstream barriers to health. So because we know that we can't improve our member health outcomes unless we're really addressing the context in which they live, work, and play. So that is really the key, I think the really heart of our bold goal strategy um, is addressing social determinants of health and health related social needs through a lot of different levers. And this really helps connect it to our business strategy as well as just a broader population health strategy, because we are looking at making measurable impacts on our members' health. So our work has really, has these community partnerships to really screening our members for their health related social needs, connecting them to community resources, establishing benefits, and really trying to bolster that social care infrastructure of the communities we serve. We do acknowledge that each community is very different. They have unique barriers, they have unique needs, and that's really been the focus of our population health needs and the strategies and the collaborations that we formed at the community level. We we really have to identify those stakeholders, which Jess will speak more to in here in just a minute, but we have to identify those stakeholders who influence all these pieces of the pie so that we can improve health outcomes. And Jess, I'll hand it back over to you.
Great, thank you. And as Stephanie described, social needs, risk factors, determinants of health, they're very multidimensional, and they'll require various forms of support and participation from disparate sectors across the entire health ecosystem. So that's kind of this infographic that you're looking at here on the screen. We're very intentional about cultivating these multi-sector or cross-sector partnerships. We at Humana, we've partnered with dozens, likely hundreds of stakeholders across the bold goal communities that Stephanie described. And we've done that at the individual, the system, community, state, and federal levels. We've worked with private businesses and startups. We've worked with local organizations like public health departments, libraries, food pantries, larger health systems, academic institutions, national associations, a number of nonprofits, and even government agencies. So I'll give you a current kind of more relevant example of what that partnership looks like. Looking at a program that we've launched in Jacksonville, Florida. We've partnered with the University of North Florida, their Brooks College of Health and Nutrition and Dietetics. We've also coupled that partnership with local hospitals, and this is in an effort to support food security among homebound older adults in Northeast Florida. And this collaborative program recovers food from local area hospitals, food that would normally just be wasted or thrown away. We've repackaged that food into really beautiful, healthy meals. And then the meals are delivered by University of North Florida students to older adults who have been on the wait list for Meals on Wheels. It's a really cool concept, and really, I think, quite a perfect example of these types of multi-sector partnerships that we're seeking, these partnerships that really aim to improve population health. And there's a growing body of research that demonstrates that these networks of community organizations, these networks that are working together, they can have significant effects on the health trajectories and social determinants of health within these communities. And there's evidence that health and social interventions are much more likely to succeed when you see them implemented through these really strong and connected multi-sector networks. So that's just kind of a little taste, a little teaser of what we do at Humana. But I'll turn it over to Glen to share a little bit more about the data that helps us actually measure the impact of this network connectivity. Glen?
Fantastic. Thank you, Jess. Yeah, so this was has been a really interesting adventure for us on the research side as well, for our team at the Systems for Action National Program Office. As we began to hear about Bold Goal and the initiative, recognizing that this initiative, as designed by Humana, really was designed to achieve a lot of the things that we are interested in studying through Systems for Action, in terms of looking at ways of building stronger connections between organizations working in medical care, working in public health, and working in the social services field. And then we further recognize, as we looked at the places where Humana was implementing Bold Goal in that first wave of implementation, we realized, oh, we've been capturing data from those same communities for a number of years now through a large longitudinal survey of communities that we have been conducting, called the National Longitudinal Survey of Public Health Systems. So that connection, seeing Bold Goal as a system alignment strategy, and then seeing from a research and data standpoint, wow, we've got data on these communities where Humana and Bold Goal has been working. And we've got data on a whole host of other communities that where Bold Goal has not been implemented. And that's where we started to see the research design kicking into play. So this slide kind of gives you highlights of the research design and methods that we've used. Again, at the heart of our design is this longitudinal cohort of communities that we've been following since 1998 as part of the National Longitudinal Survey of Public Health Systems. I'll talk a little bit more about that shortly. If you've attended this webinar in the past, you'll know that a lot of our intramural research studies that we conduct in SDOH, that our internal University of Colorado team conducts, leverages data from this longitudinal survey of communities. And so this survey allows us to measure the structure of community networks that exist in each of these communities around the country. And by structure, I mean the kinds of relationships that exist between organizations in the community that are working together on community-wide health improvement activities. More on those data and specific measures here in just a moment. And again, using our data, this longitudinal cohort, we have data on the networks, the community networks that exist in the 7 Bold Goal communities that were the first cohort of communities where Humana implemented this strategy. And importantly, we have data on those communities before Bold Goal was implemented. And we especially use data from 2012 and 2014, the years most proximate just before Bold Goal came into implementation around 2015. And then we also have data on those same communities for 2 time periods after implementation, in 2016 and in 2018, because our survey is fielded every 2 years. And we've got data not just on the Bold Goal communities, but on the rest of those 360 communities that have been a part of our cohort for all these years as well. That allows us to construct a comparison group, to have places where Bold Goal was not implemented, that we can compare those communities to places where Bold Goal was implemented. Obviously, Humana did not take our cohort and just randomly select communities in which to implement Bold Goal. That would have been nice from a research perspective, a randomized controlled trial. But they did not do that. They had specific reasons, as you heard Jess mention, for choosing their strategies. So we always have concerns in that situation about, well, our comparison group communities may not be equivalent to the Bold Goal communities that were purposefully selected by Bold Goal. How we get around that problem, the potential for unmeasured confounding between Bold Goal communities and other communities, is we use this synthetic control group method. We take our full population of communities that are not Bold Goal communities, and using a statistical process, we weight those non-Bold Goal communities so that they look as close as possible to the Bold Goal communities on all the characteristics that we can measure for those communities: demographics, socioeconomic characteristics, and health system characteristics. And then what we use, once we've constructed that synthetic control group weighted to look like the Bold Goal communities, we then use difference in difference estimation, a very common quasi-experimental method now used in the social sciences to estimate the potential effects of Bold Goal on the structure of these community networks, how dense and how connected are the community networks, and looking at bold goals' impact on the connectedness of those organizations working together. The last piece here mentioned in that last bullet, another kind of novel methodology we mixed in here, is we used what's called a surrogate index methodology to simulate the potential long-term effects of bold goals, network effects on health and economic outcomes of interest. As was mentioned, bold goal was started in 2015, and so we're now several years beyond that now. But if the ultimate goal for a bold goal is to move the needle on health outcomes, that's probably going to take more than a couple of years. And so that's a problem we all face with these kind of studies. We're trying to change the structure of delivery systems. We'd like to know what the longer term health effects would be. We use the surrogate index methods to project what the long-term effects, health effects, and also economic effects might be from bold goal, by using the changes that we see in network structure and then project those network changes onto longer term changes in health outcomes. Preventable mortality is our measure that we use, and also economic outcomes. We use a measure of Medicare spending per person in these same communities. And there's some interesting econometrics that go behind that, which I'm glad to take questions on that or share more details in the methodology offline. Okay, a little bit more about the data sources. This longitudinal survey of public health systems is our core data sources. It follows a cohort now of 600 communities across the U.S. There's an original group of about 360 of the communities that are larger metropolitan communities. That's what we focus on here because the bold goal communities are all larger metropolitan areas, and we use that metropolitan cohort in this analysis. The survey goes out to local public health officials in each of these communities every 2 years, and those local public health officials report on a set of 20 recommended population health activities. They tell us whether or not these activities are done in the community, and they tell us about the range of organizations that collaborate in implementing these 20 population health activities. The activities that we measure are originally recommended by the Institute of Medicine way back in 1998 as part of their landmark public health report, and more recently have been recommended in a series of other National Academy of Medicine reports on population health. So we measure the scope of those activities that are implemented in each community, and we measure the network of organizations that collaborate in helping to implement those activities. And using that data, we construct a variety of network analysis measures that are commonly used to characterize the structure and composition of networks, collaborating organizations that work together. Measures of density, how many collaborators there are, measures of centrality, what kind of coordination is going on by a central actor as well. And we link these data with a number of other secondary data sources that tell us information about the demographic and socioeconomic characteristics of the community being served, and also from data from the Area Health Resources File that tells us about the structure of the healthcare system and marketplace in these areas as well. This slide is a quick slide on some our network analytic methods that are used as part of this strategy. Our survey gives us measures on each of these 20 activities, and for each of those activities, it tells us the range of organizations that help to implement those activities in the community, including public health, medical care organizations, and a variety of social service organizations like you see here. And then by aggregating that data, we can look at for any pair of organizations in the community, we can measure how strongly they're connected with each other based on how many of these 20 recommended activities they collaborate together in implementing. And so that's how we roll up our survey data and make it a traditional network analytic data. We're able to measure the strength of connections between any pair, any dyad, any pair of organizations in the community by how many of these nationally recommended population health activities they are collaborating on to implement. Okay, let's give you enough background. Let's give you some results. What have we found? about what are we learning about the impact of bold goal on the structure and the composition of community networks. This slide just compares the data from the 7 bold goal communities to the reweighted synthetic comparison group constructed among our other non-bold goal communities in this cohort. And as you can see, we were able to, using the statistical reweighting method of synthetic control group analysis, we were able to construct a comparison group of communities that look pretty close to the bold goal communities in terms of general demographic, socioeconomic, and health system characteristics. All of these variables that you're seeing here, there are some small differences between bold goal and the comparison group. None of these differences reached statistical significance, fortunately. But you can see the comparison group communities have a little higher proportion of non-white populations compared to bold goal. The bold goal communities have a couple percentage point higher poverty rate on average. And then looking at the health system characteristics, the bold goal communities have a little bit higher health resources in terms of physicians and hospital beds per capita compared to the comparison group, but again, not significantly so. Just to make sure that to protect against the bias that might be generated by any residual differences between bold goal and comparison group communities, we do use multivariate statistical models to control for these same characteristics in our models to further, hopefully, isolate the impact of bold goal on the networks and reduce any potential for residual confounding on these characteristics. So what impact did bold goal have on the community networks that were operating in these communities and the connectedness among those networks? This slide summarizes our synthetic difference in difference estimates of bold goal's impact on community network structures in each of these communities. The first line you see at the top of this graph shows you the impact of bold goal on overall network density, which is basically a measure of how many organizations are working together on population health activities. We estimate that bold goal on average had about resulted in about a 10% increase in the overall density of organizations working together on population health activities. Sizable and significant impact by 2018, which is again about 3 years after the implementation of bold goal. We did not see an effect of bold goal on our overall measure of network centrality, which is to what extent is the network being driven by a single actor in that network kind of managing and steering activities. So bold goal resulted in denser networks, but not more centralized networks. The networks are still pretty pretty decentralized in terms of what roles organizations are playing in the networks. Now, the remainder of these measures are measures of sector-specific measures of participation in the networks, and measuring basically how large a role are each of these sectors playing in the community networks and helping to implement population health activities in the networks. And you can see for about a little over a third of these sectors, bold goal had a significant impact in increasing that sector's role, that sector's connectedness and embeddedness in the community network. For example, the hospital participation in the networks, we see again also about a 10% increase in hospital participation in these community networks in the bold goal communities as compared to the comparison group communities. We see an even larger increase in health insurer participation in these networks. Perhaps not surprisingly, given this is bold goal, this is a Humana health plan sponsored initiative. Probably a large part of that increase is Humana's role, the role that Humana is playing in helping to pull together these networks. So this was expected, but still confirmed. Good to see that confirmed in our data. We also saw significant increases in network participation by employers, by faith-based organizations, and by schools. All of those having sizable, 10 to 15% increases in network participation in the bold goal communities as compared to the comparison group communities. And you can see there are also some other sectors where we didn't see as large or significant increases as well. I would note that almost all of these sectors, you can see the point estimate is positive, meaning that there was a tendency toward more engagement in the network by sectors like the overall nonprofit sector, or other units of local government or state government. But you can see the confidence intervals for some of these other sectors are quite large, and so we can't reject the null hypothesis of no impact. But overall, you can see we do see, looking at overall, the main takeaways here is that bold goal appeared to have a sizable impact on the overall size of the network collaborating on these activities. And then also had significant effects in terms of increasing participation in the networks by a number of key sectors, including hospitals, physicians, health insurers, obviously, but also employers and faith-based organizations and schools. Okay, final piece of findings, and then we'll open it up into have a discussion about what these findings mean. This next slide shows you results from our surrogate index methodology, where we use the effects that I just showed you, these effects of bold goal, the estimated effects of bold goal on network structure, and then use those effects to estimate the potential longer term effects on health and economic outcomes of interest. And we use a 10-year window for projecting those longer term effects. Again, this analysis is based on earlier work that we've done and published showing that communities that increase the strength of their networks over time, those communities over 10 years see significant reductions in preventable mortality rates in the community. These are deaths before age 75 from preventable conditions. And these communities also see that communities that strengthen their networks over time see reductions in medical care spending, Medicare spending per person, reductions in the trend in medical care spending per person over time. So we use those earlier results that we've published already with our survey data, apply them to the network changes that we estimated for bold goal in order to get a projection of what the long-term health and economic effects of bold goal could be over 10 years if those short-term network changes that we saw are maintained over 10 years. And this slide shows you the results from that surrogate index analysis. We project that if the network changes estimated in the last slide are maintained over 10 years, that would result in about a 5% reduction in preventable mortality in these bold goal communities compared to the comparison group, and a little over a 6% reduction in Medicare spending per person in the bold goal communities over 10 years, again, compared to the synthetic comparison group of non-bold goal communities. Both of those estimates are statistically significant, again, suggesting that there are potentially meaningful and significant health effects and economic effects that could be realized by bold goal if those short-term network effects that we observe are maintained over 10 years. Okay, I'm going to turn it back over to Jess and say, what does this all mean? Where do we go from here with this?
Oh, that's great. Thanks, Glenn. So this is just a summary slide, and then we look forward to really digging into questions. But broadly, as Glenn described, we saw increased network connectivity in bold goal communities, and they were driven by increases in network participation rates among employers, hospitals, health insurers, physicians, schools, and faith-based organizations. And next, we'll talk about some of the implications and some of the keys perhaps driving some of those findings. So one key here is sustaining the strength of the network density, participation and coordination. And this can be quite challenging. And we know this firsthand based on the work that we've done in our Bold Goal communities. Now, our study did not measure the sustainability of those individual partnerships or, between those nodes. But we can share a few things, or maybe infer a few things from what Glen shared, and even from our own observation of our Bold Goal communities. And I'll start by saying we know that Humana is not the hub or driver in these networks, and that we think is what allows us to be sustainable. And we saw an indicator of that in that, as Glen just mentioned, the centrality was not non-significant. Meaning network participation in our Bold Goal communities is generally more distributed across our partners, and those partners are from across the health ecosystem. So I'll also note that in order for these multi-sector partnerships and networks to sustain, they need to evolve. So like the food repurposing program in Jacksonville that I mentioned earlier, in order for it to sustain, it had to evolve and grow and change. So the University of North Florida, they started to introduce new partners into the program. They started to bring in additional food sources, not just looking at hospitals, but looking at other opportunities to pull in and repurpose food. They brought in new client populations, and in the future plan to develop a toolkit to replicate the program in other universities. So the sustainability thing is a big part of this story. I'm going to turn it over to Stephanie to talk a little bit more about the importance of scale in this work.
Thanks, Jess. Yeah, I mean, building off of discussing sustainability, one of the reasons that we have these Bold Goal communities is not just because, well, we only care about those members and communities in these 16 places. But they also provide kind of a learning lab, a place for us to innovate and really learn how to form these cross-sector partnerships and look at how we might bring these partnerships or addressing these specific needs into our and how we address the needs of our members. So how do we think about using what we've learned about working with university and nonprofit partners and creating a benefit that is scalable and sustainable for seniors or for Medicaid beneficiaries who might be able to benefit from that in other places. It's been really important that as CMS and as states have loosened regulations, given us more flexibility to more directly address social needs, that we do this in a way that leverages those partners who already do this work, who already do it well, and know much better than we do how to do some of these things in a way that we can, instead of not just referring, but making it a sustainable, making it a scalable model through the partners that we picked. So we're really committed to learning and applying what we're learning in these communities to our members everywhere, whether it's through a benefit program, through a quality improvement program, or better syncing up with care coordination from both the clinical and social and behavioral health perspective. Glen, I'll hand it over to you to wrap us up for the next couple.
Sure, and I might touch on these last couple of bullets on this side. First of all, what might these findings have to say about the continuing COVID-19 context that we're in? And I think they actually say have quite a bit to tell us about strategies and paths forward. We know from other work we've done with these network data, along with other studies that are ongoing through the Systems for Action program, like Danielle Varda's work and others, that these community networks have been really pivotal in helping communities respond to COVID-19 and to address the social and economic sequelae that have been generated as a result of COVID-19. So I think having now this study added, suggesting that an initiative like Bold Goal can actually move the needle on these networks, can make these networks denser, more connected, that would suggest that this is an incredibly important strategy for thinking about how we move forward and make communities more resilient to a whole variety of shocks to population health. Certainly, infectious disease shocks like COVID-19, but as we're thinking about climate change now and a whole other host of factors, we know how important these network connections are. And we've got an example here of one intervention that is successful in again, making those networks more connected. The last point on equity, diversity, inclusion. We've also been doing some work in this space with our network data, and I know several other S4A programs have been studying these issues as well, given our heightened concerns about racism as another public health crisis that we face here in the U.S., and about persistent health inequities that a variety of historically marginalized populations experience, including Black and Latino and Indigenous populations, including LGBTQ populations, rural populations, and others. And again, other work that we've done with these network data suggests that if we want to make progress with closing those inequities, we have to think about how to make our networks more inclusive and more diverse. How do we bring in community organizations and partners that are working with those historically marginalized populations and communities, working with the stakeholders that are experiencing systematic and structural racism on a day-to-day basis. Networks are one pathway for reaching those populations, and by making our networks more diverse and inclusive, there's a growing body of evidence suggesting that's a pathway to tackling these health inequities in the long run. And again, we've got an example of Bold Goal as a potential mechanism for intervention for doing that. Okay, so I think we're ready for questions. I'm going to end just with a couple of thoughts about just limitations and being honest about that. Obviously, this is a quasi-experimental study. This is not a randomized controlled trial of Bold Goal. So some of the findings that we estimate and potentially attribute to Bold Goal could be due still to unmeasured differences between the purposely selected Bold Goal communities in our comparison group. We've used the strongest possible quasi-experimental methods that we could come up with to try to tackle those sources of bias, including the synthetic control group methodology, along with the difference in difference analysis to wash out those factors. But there's always the possibility of sources of bias with this type of study. We need to confirm it and continue to study this intervention along with others to deal with those issues. I would say a strength of this study, a unique strength though, is the source of data that we use here, the longitudinal survey of public health systems. It's public health officials around the country reporting out these measures. Stakeholders that are not directly involved with Humana or Bold Goal. So it really is an independent and a third-party data source that we're using to evaluate Bold Goal. And our respondents as public health officials are also kind of third-party stakeholders reporting on what's going on in their communities. So that is a strength that we think is kind of that helps to balance out some of the limitations as well. So we would love to hear questions. We've got plenty of time to get to questions now. I would ask, it will help us out if you can use the Q&A box. If you're with us on the Zoom webinar, you should see a Q&A box down at the bottom center part of your screen. If you click on that, you can submit a question, and we're going to start moving right through those questions. And so first one, and I'll just reference first names. Sarah asks, how can a community agency in the bold goal communities become involved?
Great question. So probably the best place to start is going to our website, populationhealth.humana.com. There you can find information on all of our communities and programs and contact information. So that would probably be the easiest.
Fantastic. Thank you, Stephanie. Alyssa asked, what's the actual theory of change behind bold goal? Sounds like it's related to network connectivity. Is there an assumption that connectivity is facilitating or preventing positive health changes? Jess, you want to tackle that?
Well, it's a really good question, because when you first asked that, Glenn, or it really depends on the intervention in some ways. So if you pull it back and look at it, at a population level, as we did in this study, using the analysis data, Glenn, I think that actually aligns better to some of the work that you've done around the connectivity of networks, and maybe you might describe, the mechanism by which that network, has an impact on big health outcomes, healthcare utilization, mortality. I know that you've published some of that work elsewhere. But before you get into that, I'll say, depending on the community need, the particular intervention, I think you can dig in at maybe more of the system or community level, or even the intervention level, and apply a broad range of health behavior theories to describe how those networks are working, how the work is actually being disseminated, how the community is benefiting from that good work that's happening in the bold goal community. So it can get quite complex in a hurry, but I'll punt to Glenn to maybe answer the system level question. And then certainly as a follow-up, if you want to learn more about maybe the specific interventions within these bold goal communities and the potential theory or mechanism that's driving that work, we've published some of that work in the peer-reviewed space in the form of posters and manuscripts. And then we're also really open to just talking about the work that's happening and answering your question more thoroughly. I hope that isn't a lame answer, but I'm happy to keep that discussion going. Glenn, did you want to take a stab at that if I kind of missed the context of the broader mechanism at play?
Yeah, no, I thought you did a great job, and I do think it is, that theory change. It centers on that notion of connectivity. Another way of thinking about it, you can look at the specific population health activities that we measure in the survey, which are based on a large body of evidence that the National Academy of Medicine reviewed when they recommended those activities. And those are core public health activities that, for the most part, we know are only effective if they're implemented by collaborative, broad collections of stakeholders working in the community. And some of them are based on the Larry Green's pre-seed, proceed model, a classic health behavior community change model that goes back 4 or 5 decades around stakeholder engagement, assessing needs and risks and doing shared planning and priority setting. Those kind of activities are measured in our survey, and again, their theory of change is based on both health behavior change theory as well as a large body of evidence now suggesting that no single organization can implement those activities by themselves and have them be effective. They're by nature collective action activities that you've got to, and the networks are a way of helping organizations work together to do those things. Great question. We could probably spend the rest of our 12 minutes. But we won't. We got some other good questions. So Donna asks, this is, I think, back to your Jacksonville example, Jess. Are the students paid to do the food delivery activities? What implications are there about sustainability for volunteer versus paid engagement, I guess?
Yeah, that's a great question, Donna. And when you type that into the chat, I had to think back on what I've learned from our partners. Dr. Lori Wright leads the program at University of North Florida. And I'm not 100% sure. I'm inclined to say that they are student volunteers, but there could be some kind of fellowship dollars. Maybe some of those students are getting paid through other internships or means. Maybe they're getting credit hours to participate, so they're getting paid in various ways. Let me follow up with you, because that is an important component of the model. As you point out, there's pros and cons to that decision around payment. So happy to follow up, get some real specific information from Dr. Wright, and would be happy to get back to you.
Fantastic. So Christian asks, what are some unique aspects of the Bull Goal for Medicare populations? And do you restrict your Bull Goal program to only Humana members?
I'll take a stab at that. So I'm going to answer the second part first, which is it depends on how you're defining the program. You know, our role in the community, you know, is really to listen to the community and be part of the conversations around population health and promote those connections. But at the same time, we also are looking at how do we effectively address the social needs of our members? So and a big piece of that is what we're allowed to do. We're a health plan. We can't just, you know, the humming part of us is heavily regulated. So, you know, we do have to, when we're doing something like what Jess talked about, if we're directly funding it, you know, where there are more restrictions about who and how and all of those things and how it's being paid for. And so the role in the community is both. It's definitely thinking through how do we remove those social determinative health barriers in the community and being part of those collaborations, while also thinking through, so for our members, those our immediate customers, how do we improve their health outcomes? So a lot of our Humana's business is heavily Medicare. So a lot of those member-focused programs will be in Medicare. There's also been in the past couple of years, been a lot more flexibility that we've been allowed by CMS to really more directly address health-related social needs, these non-primarily health-related benefits and things like that. So, you know, we really have identified specific social needs like food insecurity and loneliness, and that are particularly acute for our senior population. So a lot of our work, and again, because we don't have forever to talk and go through all of it, please go ahead and on our website and check out the progress report and some of the things, those proof points from our communities. But, you know, we also have a Medicaid population and commercial population, TRICARE. So we really are trying to think through how do we address the needs across all of the communities we serve.
Fantastic. I'm going to skip around a little bit because we've got some great questions, and I know our time is precious here. Interesting question about from Colin about can you speak to how Humana thinks about incentive structures for investing in upstream population health, community health activities? How is the success of these investments being measured and benchmarked internally by Humana? Interesting question.
Okay, that's a really good question. Really going back to that sustainability model, because we have to demonstrate the value of Bull Goal and the investment that Humana is making. And fortunately or unfortunately, we don't usually have a 10-year window to demonstrate that we're having a measurable impact. So, you know, there are a variety of ways that we think about it. One is direct member health outcomes, particularly with seniors who are chronically ill and have complex social needs. It's sometimes we're able to kind of see those impacts in more near term. But, you know, we would not be, we also have to think about how the Bull Goal and being part of these conversations is really gives Humana credibility and builds trust in the community. So those are also values. I will say that when we're thinking about even further upstream, you know, we do have corporate partners in the partners with our Humana Foundation and others who can look at how to make strategic investments to even move even further upstream than we may be able to sometimes. Jess, what would you add?
Well, there also maybe, and it depends on which direction the individual wanted to take this question, but in terms of incentive, could be tied to our value-based, payment structure. As you think about not just attending to acute needs of patients, but looking big picture at whole person health. Yep. And understanding that you have to address everything that's happening, in their world. Our reimbursement models through value-based payment kind of gets at that incentive structure in other ways as well. So I think, we're taking a very multi-pronged approach from different sectors to try to make this easier for various stakeholders, yep. Whether it's community members, individuals engaging in health behaviors, and even health practitioners and health professionals engaging, in the healthcare system. So that might be something to add.
Yeah, no, that's a great point. I mean, Humana, we're a managed care organization, in addition to just a insurance company. So this managed care, we're accountable for these outcomes based on how CMS and the states pay us. Mm-hmm. And we have a large amount of value-based payment models, relationships with providers in Bogle and across the country. And you can see some of that, I was happy to see that there was some measurable improvement in the participation among some of our key value-based care partners in these population health activities as we connect those dots for all of the people in the health system.
Fantastic. So, question about the stability of partners and partnerships in these networks over time, and whether partner turnover affects the kind of findings that we share. I would say I'll give an answer just looking at the network data that we see in the Bogle communities we had 2 time periods after Bogle to look at the stability or the change in the network structure over time. And through that last period, 2018, the increases in network density that we saw after 2015 were maintained by that second period. We did not see any fall off or turnover in terms of network collaboration in the Bogle communities. In fact, in the non-Bogle communities, we do see a lot more of that turnover or churn in network participation over the 2-year period. So I think that more stability in network structure is possibly partly what we're seeing in the Bogle communities, and they explain how they got denser, than the other communities. But Jess or Stephanie, any other insights you have about stability of partners within the Bogle community?
Stephanie, I'll defer to you. I can offer some context, but I'd like for you to share first, given your proximity to the Bogle communities themselves.
Yeah, I mean, I guess I haven't found that partner turnover has really been an issue. A lot of our partners have been at this a lot longer than we have. So it's more the concern about, particularly in the past, with a pandemic and things like that happening, about their understanding their capacity and their both their service capacity and the kind of as we think about scaling, as we think about other, how do we become more formally partnering, there is also quite a bit of that sort of kind of legal and IT capacity that can be barriers, but turnover has not really been as much of an issue. I don't know.
I think it's a great question, and in some ways, the size of the network, can help with that. If you have more than just a dyad, like I mentioned the food repurposing program. There's a lot of partners involved there that are all kind of carrying the water, if you will, because you are going to have turnover and churn within organizations. One thing I'll just share anecdotally, it's you know, to build systems and structures, committees, coalitions, things within those partnerships that go beyond just the one individual and the champion. Those champions are critical to the success of the project, but they can't be the only thing holding it up. So things that we've done, even within our academic partnerships, is to develop decision-making committees that involve multiple individuals from different kind of positions within the different, you know, partnering entities, just to ensure that as people move on and shift gears, it doesn't inhibit the progress being made on that shared interest. All stuff that most people on the call are aware of, but we certainly see that every day in the work that we do.
Fantastic. Well, I know we're at the bottom of our hour now, so we've lots of great questions we haven't been able to get to. As we normally do, we will we captured your questions and we'll send out some follow-up information with some responses to questions that we were not able to get to live today. We will have slides available as well as some ancillary documents for folks to learn more about Gold Goal. We do have a manuscript that's in submission now that describing these findings, and which we hope will be out in press very soon, and we'll make sure to get that out. You can always track our publications on the Systems Interaction website, but we have one specifically on this project that will be coming out. It will be forthcoming soon. So thank you so much for joining us. Thank you to our colleagues, Jess Dobbins, Stephanie Franklin, and please feel free to join us in our next Systems Interaction Research in Progress. So long, everybody.
Thank you.
Thank you.